This episode of The Reality Pill is a special one. We have Dr. Chia Chi Kao, world renowned for the ponytail lift, the ponytail facelift, and a bunch of other very, very cool things that he does with the face. I love talking to Dr. Kao because he is an amazing surgeon. We do things so differently, yet still agree on everything the other one does. So it is with immense pleasure and gratitude that we have Dr. Kao on the show today. Allow me to introduce, well, everybody already knows who you are, but so this is...
No, I already know who you are.
So this is the amazing Dr. Chia Chi Kao, back on the reality pill after, well, we've been trying since the beginning of the quarantine. So it's good. We made it in 2020.
It's better than late than never.
Yeah. So it's an honor to have Dr. Kao on. He's world renowned. People always say that, but he actually is world renowned. And that's from where you were born, I think, in Taiwan, through Seattle, through America, LA, everywhere. Dr. Kao is known for both facial work that he does and the body work, but today we're going to be focusing on a lot of the face stuff and your famous ponytail lift, and we're going to talk about fat grafting and fox eyes and threads and all that kind of stuff. When people have questions, if you guys have questions, go ahead and put it down in the text boxes below. We have a bunch that we've kind of accumulated over the past 2 weeks since we mentioned we're going to be doing this. So we're going to answer all those towards the end. Dr. Kao, if you don't mind, I'm going to ask you some stuff first that I'm curious about, because I've had patients who I've seen get fat grafting done and it doesn't survive. It doesn't last. It looks weird. Different things happen. I've seen you do fat grafting many, many times, and I always love it. What have you kind of noticed in your practice when we see this kind of nasty or problematic fat grafting? Because some people think if you take fat from your body and put it in your face, it's totally natural. Is that true?
I'm a proponent of fat grafting. I do fat grafting probably in about 99% of my the faces that I do. So I do a lot of it, and it has a learning curve. Obviously, I mean, it's not something that just you have to get kind of hang of it. I started fat grafting. My very first case was when I was a resident at USC. And this is when Sidney Coleman first came out.
Coleman years.
Yeah. So Sidney Coleman first published his series of facial fat grafting and things like that. And he has specific technique of a centrifuge, and he has his own Coleman cannula and so forth. As a resident, I read about it. I was excited about it. So I actually got the Coleman cannula and so forth, and I did my first case as a senior resident, and it was one of these women had absolutely no lips at all, like a little paper thin lip, and I remember her name is Sophia, and she came, and I said, okay, I'm gonna have to do this. Like, she only have one chance to do it well, because they don't have a lot of money. They go to a resident clinic.
Right.
So I injected, I was like 10 cc, which is crazy amount of fat in the lips. Like usually you put in maybe I'll put 2 or 3 in the upper, 3 or 4 in the lower, but this is 8 in the upper and 10 in the lower. It's like, when I finished, her lip was like this big, and I was actually embarrassed, So I had to give her a mask to go outside the hospital because I was so embarrassed by the result. And then things came down, and I never saw her. Then she kind of lost the follow-up. Like, she didn't come back. I was like, oh my God. And then it was 5 years later, I saw her at a wedding. This girl came up and tapped me on the back and said, Dr. Kao. I was like, oh, so hi, how are you? And it says, I'm Sophia. I said, really? I said, Sophia, look. And her lips were natural, they were full, and they were so beautiful. And I said, oh my God. And I didn't have a phone with me at the time. I took a picture, but she said, people always ask me, they say that I wish I could have lips like yours. And that's with fat grafting. But over the times, when you do fat grafting in the face, it gets trickier, especially in the lower eyelid area. That's the most problematic area in the face. In the jawline, in the temple, in the cheeks, usually you're injecting deep, and the skin is thick over those areas. So really, it doesn't really have a lot of downturn, really. But the thing that really happens with fat transfer is lumpiness, right? And so those kind of areas, they don't really kind of show up. In terms of back in the days when I was using a comb and cannula, the cannula was really thick. It was really big. So this parcel of the fat you're harvesting is really kind of big. So when you put bigger parcels of fat in, like under the thin skin lower eyelid, that's usually kind of problematic. And I did have some problems early on in the first year. I had like 3 patients that had some lumpiness that I felt like, oh wow, okay, this is not good. And then so I realized it was because of the cannula size was too big. So I had a company make me a very small like micro cannulas, just like 1 millimeter side holes. And I've been using that since, and now.
And this is like early 2000s, late 90s.
This is well, I'm old. So yeah, this is 2001, 2002. So back then I was already modified it. So to make a long story short, I think fat transfers is safe for the most part, okay? And in the face is pretty, as long as you stay deep, is pretty good. The only worst thing that can happen is that it doesn't really take that well. And I can get into that a little bit later on. So there's certain patients that doesn't take well, okay? That you have to kind of let them know ahead of time. And in the lower eyelid area, you really have to use really fine harvesting cannula. And now there's actually new products out there that actually will cut the grafts into smaller sizes for you. And you can, it's not nano fat, but it's a micronized fat still that you can use to help prevent some of these problems. So harvesting makes a difference. Injection techniques make a difference. Isolation makes a difference. How you isolate it, how you wash it, it all makes a difference on fat survival rate and so forth. And also the most important thing is patient selection, really. I mean, I think when you have older patients, when they're 65 or over, they tend to have, the fat tend to be different. They tend to be more fluffy, more oily. When you harvest it, just more oily. It doesn't really take as well. So those kind of patients because I usually centrifuge my fat, so I have to instead of 5 minutes, I spend in 3 minutes instead. So a little bit less traumatic for them, okay? And patients who are younger, who are in their 30s or 20s, or sort of premenopausal, you got to be a little careful with fat transfer in the face, because they may gain weight in their 40s and they can grow a bit.
Yeah.
So you have to be very.
Yeah. So I actually wanted to go over that. So that's something I think patients need to realize too, is when you go to someone like yourself who's a fat grafting expert, you're at like the top of the top. Everything sounds easy. And it sounds like, okay, there's no problem, it's great. But we've seen complications from other doctors where they come in and they didn't do fat grafting well. And fat grafting, even if they did it well at the time, they didn't really take into account that, hey, this patient might go through hormonal changes, they might go through menopause and get changes, or they might have weight gain in the future if they're not somebody super stable. So what have you seen go wrong that you're about to talk about?
I have seen, obviously, the sausage grafts that people show up with from that I see sometimes. And a lot of time people say that, well, that's really not correct. Well, it's really surgical. Mm-hmm. You have to make a big incision and go in there and cut out the fat grafts. And it's a very, very difficult situation. But actually, when what you can do is you can do a little tiny, just a stab incision with the same cannula that you injected it, and you can sort of break it up. A lot of time, especially in the early phases of you see somebody who's early, you may be able to get it. Maybe it's just a sort of an oil cyst that's forming, before it gets encapsulated into like a harder lump. You can actually just put a needle in there and kind of break it up, and that'll help a lot. Okay, so you don't need to you can just do it in the office. It's not a surgical mandate.
So have you done liposuction to correct fat irregularities, or over fat grafting from somebody else, or heat therapies? What kind of things have you tried?
What I usually do is the following. I can put a little bit of, I can actually under a local, I can just insert a little cannula and I can break it up and take a little syringe suction. I can break that up a little bit. And usually that takes care of it probably 9 out of 10 times. That'll just go away.
Have you used Kybella for anything like that, for fat irregularities from grafting?
No, I have not, especially because most of the time the fat grafting problems are in the lower eyelid junction, lower to cheek eyelid area. So I don't really want to use Kybella there. It'll swell up, it'll be very painful, and then I just don't think it's probably a great place to use it. So I don't think you need the Kybella there.
Do you have an opinion on Kybella for the rest of the face in general? Do you ever use it?
I went to the Kybella training because when it first came out, I was curious as to how well it worked. And the problem with Kybella is that people use it for down here in the submental area, and it's multiple treatments, like 3 or 4 treatments. When you inject it, it can be fairly painful, and it swells up a lot, and you get kind of a froggy kind of a response, an inflammatory response, and then it takes about 3 or 4 weeks to go down, and then you get another treatment. Then you got to get another round of it. Yeah. So by 3 or 4 months later, you get you might get the result you want. But with one little tiny stab incision this big, I can do a little tiny micro liposuction.
Much faster.
I can take care of it. I can take care of it under local in the office, which I'm sure you've done a million times. And so for me as a surgeon, it really doesn't make any sense at all, because I can take care of that problem probably with less agony, less pain, and more efficiency than Kybella.
Yeah, I agree. And what do you think about 2 types of things? One is nanofat, and the other is the fat stem cells that we don't use in the US, but I've seen you do something with harvesting fat, and then kind of they go through this cloning process, or I'm not sure what it is. Do you use that for anything ever, like the nanofat, or other than just fat grafting?
So just for the general public, nanofat is actually not fat, right? So what that is you do the liposuction, collect the fat, and then the way it is made is that you pass through this sort of 2 syringes back and forth to break up the fat cells. So in that solution, the substance is really liquidized fat. There's really no fat cell. The fat cells are broken out, and then what's left over, maybe some stem cells that's there. So when you inject it in a nanofat, it really doesn't offer any volume. So it's good for retexturization. Maybe I'll use it for lower eyelid area, for like maybe dark circles and so forth, and maybe some really kind of funky, like really thin skin area in the lower eyelid. I think that's very good for, or like really, really sort of fine lines and wrinkles that may be helpful for retexturization. But for volume, for a lot of people that needs a volume replacement, is still micro fat. Mm-hmm. So you still have the structural fat. The fat cells are there. It offers volume. It's not totally broken down.
Yeah, and what do you do to increase take rates of regular fat that you inject, or the microfat?
Okay, so what you saw me doing like on Instagram, like is sort of increase the number of stem cells.
The pink stuff.
I have taken the fat, harvested the fat, and then I through enzymatic degradation, then I spin the solution down and make the stromal vascular fraction, SVF, and then you isolate, then you spin it out again, you get these stem cells, and then you harvest more fat, and you take the stem cell and add it to the fat, so it's kind of like high octane fat. So this fat that you actually have has millions and millions more stem cells, and then you inject that into the face or the breast and so forth. And so that's one way to do it. I did a lot a couple of years ago, but then FDA came down on people using, because they feel nervous about using enzymatic degradation. So I kind of backed off on that. So in Denmark, with my colleagues, he has a company called StemForm. So what we were doing is taking the fat, isolating the stem cell from it, then we culture expand it into billions and billions and billions of cells in a petri dish. Then we collect them into billions, and then we harvest more fat. We inject it into the face, and in the breast, he has shown like some really remarkable takes. In the breast is actually quite remarkable. I wish I could show you some on the Zoom thing, but I can't do it right now. But he's got some really excellent retention rate from very small amount of fat.
Mm-hmm.
Like he can grow a breast that's like a B cup into a whole cup size with just like 200 cc's of volume of fat that he's actually injecting. Normally, it would take for a cup size increase, you did go like 600 cc injections sometimes. So 200 cc or 150 cc is not that much at all. So that's actually quite remarkable. In the face, we've done it in the face, and it's a little bit more difficult to show in the face because the volume that you're injecting in the face is not like 200 cc's. Right. It's like 60 cc's. So that small amount isn't quite as good. The patient we did was actually quite really satisfied with the result because we saw a really good change in the texture and the fine lines of the skin.
Yeah, and I'm excited to use it if we ever get to do something like that over here. For now, I've been using the NanoFat with PRP, and then Dr. Mani is doing the mist technique, kind of doing, same idea and stuff. And we see such nice, just like very vague rejuvenation of the face. Like it just ends up looking better for a variety of reasons. Some people just look a little brighter. Some people look a little softer.
Well, I've been doing fat since, about 20 years ago now. And the patients I see come back, that the skin looks better with time. It just looks better and better with time. The skin texture is improving, so forth. And we know that from doing breast work for breast cancer reconstruction with irradiated breast tissue. The tissues become fibrotic due to radiation changes. There's nothing that can really cure that. The skin kind of like it's been on a grill, it's been fried, it becomes fibrotic and brawny. There's nothing really changes that except for fat transfer, because when we do fat transfer, over time it softens up, become more and more like natural, normal looking skin. So we do know that the fat and the stem cell do help the texture of skin long term.
Have you used that? I use it commonly if somebody comes in overfilled in the face and either they've been deflated with dissolvers elsewhere or I'm the one who did it. I do see deflational changes from that in the SMAS and in the dermis or under the skin where they're just not as like hydrated or radiant. So on those patients, I tend to do it all the time, doing the NanoFat with the PRP. Do you have like a system that you use? Because I've seen you dissolve a lot of patients trying to get rid of overfilled faces.
Right. Well, the overfill faces are challenging because when people always think that, first of all, I think for the general audience, they have to realize that the fillers, the HA fillers, doesn't always go away. That people think, I can just reverse it if I don't like it. But actually, it doesn't really actually go away very well. What I mean? It goes away maybe 80-90%, but like 10-5% always kind of stick around, especially those ones who has had a lot of filler load. They're very difficult to dissolve. Even if you try dissolving it many times, it just doesn't go away very, very well. When I see these massive overload patients with fillers, I have a whole talk on it. And psychologically, they're a different kind of group of population because they're sort of like hyper aesthetic. They want to look beautiful all the time, and they keep sort of searching for that so that the apex of their beauty, which is very, very hard to define for you or for them. So they kind of keep chasing that, and they keep filling and try this, a little bit of this they don't like, and they just keep getting bigger and bigger and bigger.
No shadows ever. They can't leave a shadow on the face.
Exactly. So at the end, they look distorted, and then they come for help, and then they say, where do I start? So those kind of patients, if you try to do this sort of a serial dissolving, they don't in my experience, it's hard for them to tolerate. So what I do is I have to dissolve the filler on the same day that I'm lifting them. Mm-hmm. So they can't have, so psychological, it's very hard for them to have a downtime. Their downtime defined is not because of swelling, it's downtime is when they don't look good. When they don't look good, they don't like it. So that's their downtime. So we do the ponytail lift, the cheek lift, a lot of problems in the cheeks. And then so we dissolve them on the table, And then we actually then try to get the right shape and form on the table by using the lifting techniques, and then we dissolve more on the table as well.
Do you find that you need to, well, I guess you do inject fat in those patients, but do you find you do a combination in those patients in different layers because they've kind of been deflated as you dissolve?
Yeah, so I do, once I dissolve them, I lift them, then I do add a little more fat into, because I have to kind of feather into areas, because when you dissolve them, it could be too much or too little. So it's a little bit of a guesswork in some way, but most of the time we hit it about 90%, 95% there. And we may have to tweak a little bit later on, but that's better than leaving them, over, because when you sort of serial dissolve them, it's going to take 3 months, 4 months, and for them, it's just like a 3 months, 4 months that they feel like they're just so devastated, they're so deflated, they won't even go out.
Yeah, especially when you do the under eyes and it just sinks from dehydration. I want to ask also, do you have an opinion about threads? So let's see. Let's go into this. So let's mention threads historically. I mean, I think early 2000s, they were very popular, but they were done in a different way. And there were a lot of problems seen over time with threads. So it kind of fell out of favor in around like 2010, 2012, in that time. Now they've come out with newer threads that are made of polydioxanone and other similar materials, seem to have less complications, use different ways. But I want to go through, how you and I in particular feel about threads. And there's, they're obviously not the worst thing in the world because tons of doctors are using them and many doctors that we respect use them. But we, do think they could be used, I'd say, in a wrong way and a right way for certain things. So first off, have you ever used threads in the past?
I actually was back in 2000, 2001, when the first thread it was a permanent thread. It came from Russia. I found it, and I was actually teaching using the thread as part of my lift in the cheek area back in 2000. But but after that, there was just so many problems with the threads that I didn't really use it. I didn't really teach it. It was the cadaver course that we were applying with, and we were teaching a little bit. I think that people kind of know if they know me and they know you. So we pretty much, the thread usually doesn't really work that well. Like in certain areas it may be a little bit better, but for the most part, certain areas it don't even work at all. I think that in an area of high mobility, like the neck or the jawline, doesn't work very well because you're moving, you're turning your head, the thread just doesn't work. And then in the area of cheek, maybe works a little bit, but in the area of brows, because it's not high mobility, but the tissue is soft, the brow tissue is more areolar in nature, so it doesn't really stay. So in those kind of areas, usually is really pretty much a bad idea.
Yeah, and do you think threads form collagen?
They form scar tissue. They don't.
Yeah, so so they form fibrosis, fibrinolyze.
Yeah, so it's really. I mean, I don't know. I'm sure you have gone into phases with these threads, and they're actually quite fibrotic. I mean, sometimes they're really hard to dissect around. I'm sure you've probably experienced that.
What I wonder about is, people talk about one of the reasons to use them is that you're forming collagen, but clearly it's not, organized dermal thickening and organized collagen formation. It's kind of a disarray of collagen forming and fibrosis and scarring. And the reason doctors do this is they say, okay, well, it's harmless. You're forming collagen in the deeper tissues, just like Sculptra, just like placing Sculptra in the skin. And so what effect would that have? And my thought is that if you're forming fibrosis in deeper layers, let's say you do threads once, it's not a big deal. I don't think it's going to cause a big issue. Let's say you use threads all over the place or twice, 3 times. Now you're just adding more and more fibrosis in the face. I feel as though deeper scar tissue formation will have an effect on superficial skin appearance, meaning it'll look more dense, it'll look rockier, it might not look as soft and supple, and certainly not as radiant. I've seen that in patients, and I'm wondering if you have as well.
I have seen it, yes. They do form kind of a stringy. Sometimes they look, especially in motion, when they're smiling, you do see them sort of like are there. They have a hint of a shadow, and they look a little stiff there. They do cause it, especially if they're placed superficially.
Yeah. So I tell my patients, if you're going to do some in the mid face and you're going to do a couple in your life, it's fine. I don't have an issue with that. I don't do it myself because it's just not big enough of an improvement for me to do it. When I look at it before and after, I have to, say, wow. Now, a lot of patients don't need that. They need tiny little subtle improvements, and plenty of our dermatology colleagues and injectable colleagues like to do, tiny little thread and then add some filler and Botox around it. And I think it's fine. The areas I don't see improvements and certainly see problems are the lip and the brows. And I've seen you post a lot of photos about the brow when people are doing this like freaky thing. And what do you tell patients who ask you? Because I'm sure they come to you and say, like, put some threads in my brows. What do you tell them?
No, usually they know me well enough that they don't come and ask for the threads in the brows, but they come because they've had 2 or 3 failed trials of threads in their brows. So I see a lot of brow failures, and the typical story, like if anybody you can go on my highlights, and I have this highlight, it's called thread aches. It's just what people just email me and DM me about their experiences with thread. It's only their testimonial. I don't add anything to it. And this is what they say to me. Usually for the fox eyes, it's very, the typical result is it's very painful and it hurts a lot, and it didn't last more than 2 weeks. Mm-hmm. And now the pain persists even months after. So that's the very common things that I hear people say. The things that you see on the Instagram, they never show you more than maybe a couple days out. 90% of what you see the fox eye posts, they're on the table with something like right here, because they don't have any long-term follow-ups on these patients, right? So that's all they got. If they want to show results 2 weeks later, a month later, they don't have it because it's very negligible or no results. So you don't see a lot of results at all. Yeah. So have you seen anything posted that were long term on the thread?
No. For the mid face, I've seen improvements maybe up to a year out when they did fillers and Botox with it. But that's the longest I've seen. Otherwise, typically for the brow, I see they look like freaks for about a week because they have like this weird bunching, because there's nowhere for the scalp to go. They're just bunching tissue there. And then it starts to relax, so they get into a position where they're like, ooh, I like that, even though they're kind of stiff and inflamed. And then 2 weeks, 3 weeks later, even a month later, then it's gone. The effect is gone. So
right. So in the cheeks, it works a little bit better because it depends on the patient and the age of the patient. The patient is a little younger and they have more fibrous fat in the cheek. It may work a little bit, okay, but in an older patient, the fat becomes a little bit more oily, like I said, a little bit more delicate. It just doesn't hold.
Yeah, I agree. And the worst place I've seen, I don't know if you've seen it in a lip, where you're trying to do a lip lift and you've got, oh my God, it's horrendous.
You're the lip guru, so they probably come to you for that, but I haven't seen one in the lip yet.
It's crazy. It's like, I just don't get it. Like the brow, okay, somebody can make an argument for saying, well, I do this, then I do Botox and blah, blah, blah. With the lip, nobody can make an argument for it. Like nobody ever. They say like, oh, I think it forms collagen. I'll shut that one down. They say, I think it lifts the lip. I will shut that one down. There's nothing they can argue about. It's horrible.
The difference between, I want to make it clear, the difference between the KO eyes or when I do the ponytail lift and the thread lift, the difference is the following. There's such musculature around the eye and the orbit around the brow area. And those ligaments and those musculature, they need to be released in order for the brow to be freely mobile. Okay, so you want to lift the brow, or you want to reposition, you want to turn the eyes up. So those canthal attachments has to be all released. Okay, once you release it, you do not need a lot of suspension to hold it in place. A little suspension is fine. When you're doing the threads, you haven't released any tissue at all. You're sort of forcing it to bunch it together like that. and it's not going to hold because the suture is not going to strong. It's not strong enough. So the key in any endoscopic brow lift, I always tell people at conferences and meetings that it's in the release. It's not in the fixation.
Of course.
So the release is key. So I don't care what you use. Like in the case of endobrow, endotine or screws, it really doesn't matter. It's a release that really maintains the longevity.
Yeah.
Okay. And same thing as the KOIs or the fox eye, whatever. You have to release those tissue around it so they can turn up naturally and looks naturally. So it's not just the corner eyes come up. It's the brow and the brow and the lid, and then the canthus of the corner of the eye and off the cheek all have to kind of swing together so it looks natural. So when you just kind of force one area like that, it looks freaky.
Yeah, I agree. Looks very freaky. So I've seen very commonly in Turkey and Iran, kind of more so the Middle East than anywhere, the surgeons try to obtain what they call fox eyes. And the fox eyes, they do it a couple different ways, but I've seen them do direct brow lifts. I've seen them do temporal lifts on people that are young. I've seen them do threads, a combination of them. And then I've seen them actually do canthoplasties, where they would disinsert the lateral canthus and take it sideways all the way up on somebody who's young, which can have a lot of problems. So I've seen those issues. I'm sure you've seen them and I'll go over them. But what is it that you do when you're making KO eyes that keeps you out of this risk and gets you a successful result?
This is what kind of bothers me. A lot of these sort of places that does these threads, they'll post a picture of Bella Hadid and stuff like that, and they say this is all thread, but this is not a thread result.
No, of course not. That's 100% not a thread. No.
But they make it look like a thread result, and everybody goes crazy, right? So this is what they like to post and call it. They call it a ponytail brow lift, which drives me crazy. Okay. And then so this is kind of the stuff that you see, that this is what people sent to me, and these kind of crazy looking things, and then they have these excisional stuff, which is really.
So that's what I'm talking about. That scares me. So what happens with these, just so people know, is they look like this on the table. 1 year later, that person will have a short, beady eye that can never be fully fixed again. So it goes like this, and they look asymmetric because one side is going to shorten more than the other side. And I've seen that so many times. Eyelids drop down, they go like this, they become completely the opposite of what they wanted, the opposite.
Right. So, what I've seen a lot of the upper blepharoplasty that people do in the Middle East is that they cut it so high. It's so high to try to create that lift. And I never understood in the beginning when I first saw it for the first couple of years. Then I realized this is what they're trying to accomplish. And it's really quite terrible. It really doesn't work. And then also the scars are just really bad. The scarification is just bad on those things. So for the KOI, for those kind of fox eyes, it should not be excisional. Threads don't work. It's really like I said, endoscopically, you release everything. So when I do my thing, it's really and you have to really talk to the patient, especially the patient in the States. It's a little bit different than the Middle Eastern patient. Okay, so you have like the people who doesn't want their eyes to be tilted at all. So we just say, okay, we're not going to touch that canthus area. So when I do my ponytail lift, I come down very far away from the canthus, just laterally here, so that I don't really turn that up very much. Okay, so none or mild. I go a little bit closer, moderate, closer yet, and then dramatic. So then I have to dissect all 360 degrees around. Then I'm actually putting a stitch in the corner to hike it up. And that stitch is very important. It has to be really artistically placed because you can't pull too hard. It will look weird, so forth. So it's really kind of a fine tuning of how much you turn it up. So that's more of a So it's an in-depth conversation with the patients to how much you turn up, how much they like, what's ideal for them. So so you kind of have to define that preoperatively.
Are you disinserting the canthus or no? Just supporting it with a stitch once you release around it?
I don't endoscopically disinsert the canthal tendon. That's an intertable.
Why?
So I can't.
Why? Why? Because these guys in the Middle East that I'm showing those crazy eyes that destroy the patient.
They do it externally. They cut
the canthus.
Right. You don't need to cut a canthus. You know, if you detach a retinaculum, canthal retinaculum, you can rotate it pretty well. So for me, it's more than just the corner of the eyes. It's the brow. It's
everything rotates together.
Yeah. Everything rotates all together. So that's the key to have it look natural. Because if you have to sweep all that skin one direction, so it looks like nothing ever happened.
Yeah, and that's the same way, when I'm doing a brow lift, I kind of have the same logic as you, where I'm thinking, okay, I want to get it to arch a little bit, I want it to get to arch a lot, or I really want to bring the mid-face up if I'm doing a facelift at the same time and get the canthus and everything to tilt. Then, just like you said, releasing all the way around. And it's all about that release. These other techniques where they go try to do threads and cuts everywhere and tacking, it doesn't work. It doesn't work, and people look unnatural. The other benefit of releasing is that you're not distorting the natural anatomy. You're kind of using the natural anatomy and just moving it into a better position. Versus these other techniques, you're actually distorting what somebody naturally looks like and trying to create something completely different, which never turns out well. I've never seen a surgeon alter somebody's face like you would see in like the TV show Nip Tuck and have it turn out well.
Never turns out.
Yeah, I mean, if you're a witness protection, okay, it's fine. Like, yeah, you're hiding from the mafia. Understood. You can look a little fake as long as you look different. But for anybody else, you got to keep it natural. So I want to move on to talking about the types of facelifts. I've watched your lectures when you give them, and then the last one I saw was maybe a couple of years ago, and you had said it was 17 years at that point. So it's probably 20 years at this point that you've been doing endoscopic lifting. And the ponytail lift, I'll let you define it because you can define it better than I can, but it's a type of endoscopic lift. And, endoscopic lifts, I trained in how to do them. They never had, great durability or great, motion for me. So I've kind of stuck to deep plane. And I say that because I've heard other surgeons say, oh, Dr. Kao's work, it's bullshit. It doesn't work. It's endoscopic. I've done endoscopic for years, and an endoscopic lift cannot do this, and an endoscopic lift cannot last more than a year and a half, and those kind of things. And I just want to make it clear that when people say that, whether they realize it or not, they're talking about their own inadequacies. They can't do it. It doesn't necessarily mean that you can't do it. And that's something that I've seen. An endoscopic lift is something where I could never get a long-lasting big result out of it. But I've seen yours, and I've seen your patients, and we all share patients. We see each other, whether I see them for Botox, I see them for this and that, and you do get long-lasting lifts. So what is it that allows you to get a big change, a consistent change, and a durable change?
Let me just the philosophy I have, when I was training in plastic surgery and how to do facelifts, I do my thing, like a facelift. Really, I feel like it's a misnomer because it's really not a facelift. It's actually a lower jowls and a neck lift, right? So when you see a great before and after facelift, it's usually they're showing the jowls in the neck. They have jowls, they have big turkey neck, they're gone, they look great. Okay, so it's really lower face and neck lift. So if you look at the way people age, okay, so when you look at the upper 2/3 of the face versus the lower 2/3 of the face and the neck, okay, so in the lower 2/3 of the face and neck, I really do think you grow excess skin. Because why? Because there's joints, so you're moving around, you're talking, you're singing, you're stretching. So then these tissues stretch and then they become loose, okay? The neck becomes loose and then you grow excess skin. And then for some people, the excess skin is severe and people don't, and the body's trying to gather fat underneath to support the excess skin, so you get a turkey neck, okay? But in the upper 2/3 of the face, you don't really grow excess skin, This really ages by deflation and descent, right? So cheek deflates and falls a little bit. And it's not that you grow excess skin. So my philosophy is like in the upper two thirds of the face, there's not a lot of skin to resect.
Mm-hmm.
Right. So if you look at when you're doing a facelift, like when I was doing my facelift, I noticed that, I don't really resect a lot of skin up here. It's not like there's tons of skin that needs to be resected unless, they have really super glidy skin when they're in the, maybe somebody in their 70s or 80s, maybe
right.
they will have a little excess skin there. Okay. So there's not a lot of skin to resect. Okay. And so this for me is to redrape and sculpt. And here is to get rid of if I'm doing the ponytail facelift. So I have the ponytail lift, then a ponytail facelift. The difference between the two is the neck. If I have to take out skin from the neck, then it's a ponytail facelift. Otherwise, a ponytail lift, which is one incision here this big, one incision right here this big. That I can get the whole upper two-thirds of the face, and also I can dissect down here. I can get the jawline, so everything come out this way, and that's great for like facial beautification, the sort of Bella Hadid type of modelly look with the brows and the cheeks and the sort of sculpted cheeks, and that's the ponytail lift. That was originally designed for younger group of patients. Mm-hmm. Okay, and then as I got into practice, people are going like, well, I have jowls too. It's like, what do I do with that? Well, that's so I had to figure out how to do the jowls. So then that's so two little incisions here, that's type 1. Then type 2 ponytail lift is then I add a little incision behind the ear here, this big. Then here, then I can tighten the jowls. I can thin this out. I can get the jowls to be tightened, and I can go down here. I can do about half the neck. So that's a total endoscopic facial rejuvenation. Mm-hmm. Okay, so that's a total facial. That's a great operation. Okay, and then
so that you're not cutting on any skin.
I'm not cutting on the skin. I'm just tightening the musculature. Yeah. So I'm tightening the SMAS all the way down. So people say, well, you do a great job with deep plane, right? People goes, well, do you do the deep plane? I'm like, well, yeah, it's a deep plane because when I do my dissection, I'm here, I'm between a superficial deep temporal fascia. Then I go all the way down here, go through here. So I'm subsmass all the way. And when I go across the zygoma, I'm subsmass, right? So I'm going down. So I'm in the subsmass plane, in the deep plane. And then I make a little incision here. I'm dissecting, lifting the fat off of the platysma and the SMAS, and then also I'm making another layer underneath SMAS as well. Then I'm tightening that. So basically, I'm tightening the deep plane from here to here.
Right. And here in the midface, to be clear, are you going subperiosteal and subsmass?
No, it's only subsmass. I don't do subperiosteal because I don't think it makes a lot of sense because the periosteum is very, very tough.
Yes.
It doesn't stretch.
Correct.
Right. So if I try to stretch something that doesn't stretch, it doesn't go anywhere. So for me, the money is in the subsmass plane.
So to go back to what this other surgeon said, so subperiosteal lifts are endoscopic, but an endoscopic lift, such as a ponytail lift, does not have to be subperiosteal. So
exactly.
So you're not performing the type of lift that these guys are talking about.
I have no idea what I'm doing.
Okay.
I know. So, I don't want to get into it, but
it's a different lift.
He really does not. Well, he says that he's done this many years, and doesn't work. Blah blah blah. He has no clue what I'm doing. It's completely different.
Yeah, I run into the same thing with deep plane lifts, with deep plane lip lifts. People say, no, I've been doing it for the same year. It's the same exact thing. And then they're really talking about an entirely different surgery. So the surgeon's just unaware. So this is a very unique kind of endoscopic lift where you're releasing around the brow, you're going subsmass, meaning the deep plane of the face, and then you do certain modifications around the rest of the face.
Right. So that's the ponytail lift. Now, ponytail facelift is now where I'm taking out skin, because now there's skin in the neck as you grow. So then I do it all in the back. I don't come in the front. So that's type 1, because that's what I hope to do with everyone, to get it so that there's no incision in the front of the ear. So I can do everything back here, from here to here, top of the head, bottom of the neck, from the top of the head to the bottom of the neck without any incision on the face. Yeah. So that's type 1. And type 2 is for the people who waited too long. They have gobs of skin. Yeah. They have a huge turkey neck, or they have this skin of the face in the neck that is so stretchy, what I call bubblegum skin. They just keep coming. Like, you've seen those people. You just think, okay, this much is going to come, but once you release it, a lot of it comes, and it just, and then so they. But it's not as delicious. It's not as delicious as bubblegum. No, but so what happens is it gathers a little bit in the front here. And then so I have to chase how to kind of flatten it out. So that's become the type 2. So, like people say, well, you say you don't make an incision. Well, I have to in order to make it look good. I mean, it's all about looking good, right? So most of the time, I would say probably about 90% of the patients I do, I can get it in type 1. Mm-hmm. And occasionally I will see a patient that has really like stretchy skin. Maybe I have to come in the front a little bit. So you'll add on, I've heard you call it a KOG jowl lift or a Masai neck lift, right? You'll add on like different parts. So that terminology came about. Like people always say, KO loves to like name his things. Why? A little bit, because KO does honestly, like to name his things. Well, the thing is that I say it because it includes a maneuver in the operating room that when I write it down, my nurses and my script, they know exactly what I need to pull in the operating room. So the KOG jowl lift is really coming in and get the jowls, okay? But so that's really picking this up like this and create a hollowness underneath of the OG. Mm. And that is, so it creates a S curve, the OG curve. Yeah. I say, well, since I made it, so it's a KOG, right? So it's a KOG. No, I like it. So, and then the neck, the side neck is really something that is really kind of, the idea is to really tighten the neck musculature, to create a long, skinny, tight neck. A lot of times, so I feel like when you do, for example, if you do tummy tucks, right? You see these women that get pregnant and the belly expands, mm-hmm. and then postpartum, the muscle can get stronger, but the fascia is stretched out, so it doesn't really ever come back unless you go tighten it. So one of the main part of the tummy tuck is to tighten all the musculature, mm-hmm. to tighten all the fascia. Well, I believe that the neck does the same thing, where as you get older, the neck, the plexus muscle gets floppy. Yeah. So it gets kind of loose, right? So because you turn, you stretch, you do yoga, stuff like that, it expands and then it comes back after some time that it stretches out. So these bands of forms, like these 11 bands of forms, it slides forward with gravity. It just slides forward. It makes these bands, it sort of settles like this. So it settles like this, right? So you make these bands. So really, we need to tighten that all up. Yeah, and I've explained to patients, or as surgeons, we know that the number one reason patients come in for face and neck stuff is a droopy neck. And I explained to them that the reason the neck goes first is, number one, like you're mentioning, the mobility of it. The other is that the face droops, but you have two sides of the face. So this side of the face starts to droop, that side of the face starts to droop, and they accumulate in the middle. So the neck is actually aging twice as fast as either side of the face. Everything exactly goes 2x. It's 2x, exactly. And so sometimes you do need to give it some extra love. Right. So we need to just imagine, like, if I did a tummy tuck and all I did was tighten the skin, get rid of excess skin, the bulge is still be there. Mm-hmm. Right? Because the skin will conform to the forces underneath. The skin is stretchy. Yeah. Right? So that's why you see a lot of the failures in the neck. And you see is actually because you don't do a lot of failure in the neck, meaning like after like 6 months, 8 months, a year, it really loosens up and people go, I still have all this stuff, like, I don't know what happened, So it's really, if you take time to really to tighten the neck all the way down, and your neck will be much better. You'll get a much better result.
Yeah.
So, and also you'll see the decrease in the circumference of the neck. So it looks like you'll see the neck gets skinnier,
yep.
the jawline sharper, and so forth.
Yeah.
So that's why I call it Maasai neck, because the Maasai tribe, they're known for their long, skinny necks. So.
Nice. Yeah. And so, I mean, a lot of these things that you've been adding on or changing over time is to decrease the failures, to make sure that people don't come back with excess here, excess there, things that we've kind of caught over time as we do surgeries. And
also it's over time that you say that, last time you saw it was like 17 years of experience. Yeah. But over time, like you see some of the things that you could do better. You just I've been adding on things for the last 20 years. And right now, I don't think I can add anything more on these days. Maybe one other thing, but that's it.
So a big area of failure for endoscopic facelifting was that they're subperiosteal. And I try to explain that myself to people as to why they don't last very long, is because you're going into a supremely tense layer that hasn't drooped much over time. And you're trying to lift something that hasn't drooped into a higher area when you're moving like a huge block of skin and muscle.
Yeah. So when you look at, you have subperiosteum. You have periosteum right here, right? So you have bone, periosteum, then you got muscle, then you have fat, and you have skin, right? So all those layers. So when you're drooping not at the bone.
Correct.
You're drooping not at the muscle. You're drooping the fat and the skin, right? So it's very hard to put stitches in the fat, because it's like putting stitches in cottage cheese, doesn't hold. So that's why the SMAS becomes important, right? So you try to mobilize the SMAS so you can move the fat, right? So that's where the money is. It's in the SMAS, layer, in that deep plane layer, right? So that's why when I do my endoscopy, it's in that layer, so that I can mobilize, so I can free it up, mobilize. So I can do things with it. I can move it. So it's kind of like trying to move furniture by pulling on a carpet, right? The fat's the furniture, and the furniture, and then the carpet is the SMAS. So people ask me all the time, so do you do it in deep plane, or do you do this? So it's really doing a deep plane, but we're trying not to try to do it endoscopically.
Right. And are you able to do it, or do you ever do it without lifting the brow, or does the brow always go up with the midface, or does the lifting the brow make the midface lifting more successful?
Yes and no. So I don't really, it depends on position of brow, obviously. With somebody who have a high brow position, I don't want to move it up anymore. But the necessity of the cheek lift goes up like this. It'll gather from the temple. That has to be finished. So the tail brow may come out just a tiny bit, and that's it. Many times I do that just because the cheek has to come up, and then the tail brow has to tilt up a little bit. So I don't. The answer is I can do a ponytail lift without really raising the brow much higher.
All right, perfect. So now I have this many questions that people have asked. Okay. So let's go over some of these. And there's some questions down here below as well. So, I mean, we kind of went over this. What's the difference between a Maasai neck lift and a platysmoplasty? A Maasai neck lift is much more involved. You're actually lifting the platysma laterally, not just. Did you do submental work here as well?
I do. I know that I've heard you talk before that you don't do. I heard that you don't really like to do a lot of the platysmal work, like the submental work, right?
I do more now. So that was probably 6 years ago. I was limiting it, maybe doing it on 30% of cases, 20%. Now I'm doing it on 80% of cases. So much more, because I'm doing a lot more contouring now.
So I think the Maasai neck, for me, when I contour, is really in the deep compartments of the neck. So it really is going after the subplatysmal fat and the anterior digastric muscle. Mm-hmm. And I try to leave the fat in the subcutaneous segmental plane, because that fat's important in supporting the skin.
Yeah, and do you ever remove submandibular glands or reduce submandibular glands?
Yes.
Surgeons always ask this. Where's your access? Do you go through submental? Okay.
And I do some. Yeah, sometimes I see these people, they do the segmental. They're very far back. They have to make a big incision. I try to stay very anterior because the neck skin doesn't heal that well. The scar is always depressed. So you got to stay up in the chin skin.
Yeah, I agree. Are most of your lip lift and facelift patients older and white? Oh, I'd say in plastic surgery and aging face, I'd say classically for facelifts, yes. They say black don't crack. So darker skin types do tend to age better than lighter skin types.
Yeah, I guess there might be a lot of that. I say the people say, do you ever do any color people? I'm like, of course I do.
Yeah.
This depends on who allows me to show. I have a couple of, these celebrity people, they're African American, and they're not gonna let me show. But yes, of course I do. And actually, so for Asian and blacks, for the facelift is actually really great because they tend to scar bad, poorly, so in the preauricular area. So it's actually better for that group of patients.
This is a vague question. I had a mini lower facelift 8 years ago. Should my next lift be vertical? I mean, the answer to this, you droop this way, you should always take it back up that way. It's not straight vertical, but it's pretty much wherever you can pull your face to. That's where I guess.
If the patient, if you just look in the mirror and you see like how much tissue moves going vertical versus horizontal, you'll see like there's actually, sometimes there's not a lot of movement this way, but there's a lot of movement this way. So really the natural move should be vertical and never horizontal.
Yeah, I agree. For a facelift, is it possible to get the pulled skin look if someone has big pores and thick skin? Yes, it's always possible if you're pulling in the wrong vector. And the other thing, and the great thing about deep planes and what we're talking about is you're not yanking on the smiling muscles. So the smiling muscles stay exactly where they are, and you're rolling things over them. And that's something vague that surgeons don't identify when they're doing mass plication type lifts, is that they're actually pulling on the musculature. And you do see that sometimes with threads as well. You can limit the mobility or change the mobility. And a lot of the time, the appearance of the stretched mouth or the stretched face that you see from a mass plication is not just from lateral lifting or lateral swoop deformity, as like Val Lambros described. It's also because they're pulling on the risorius muscle, they're pulling on the zygomaticus muscle and actually tensing it. And so the muscles can't relax.
Right. Well, the other thing is I see a lot with pulling off to the side, but you end up like really flatten this out on the sides a lot, in the side of the face a lot. And because there's a lot of tension on this area. So that's another thing I see a lot. That's sweep, right?
Yeah. How are your two facelifts different? What makes one procedure better than the other? So this is actually interesting because what people don't understand is a good surgeon is a good surgeon. It's, we have different techniques. When patients come to me and they ask about Dr. Kao's technique, I actually love when they ask me about it because I can say nice things. And I'm like, and they're like, but is it different? But what's different? I go, it's totally different. We just do it differently. And I go, you look at the photos and you figure out what your taste is and you figure out, what makes sense to you. And it's not that one is better than the other. It's that it's two different surgeons doing two different things, two different ways. And there's no right way or wrong way. It's good surgeons.
Yeah. I mean, I think, you certainly have got some really, really great results. You're really kind of a very well-known, famous surgeon. People know you. You're also world famous for your deep plane, and you do a great job. It's great when I see those results, and I follow you on Instagram. I always see results. I've been doing a great job there. It's nice, and it really depends on the patient. On you, the consumer. It's like, you don't have to, whether you buy Gucci or Louis Vuitton or Hermes, it's your taste, right?
Are you a Ferrari person or a Lambo person? It's all good.
It's just they all are good, but it's just, so what are your tolerance for some of the issues that people may have? So you have to so I always say that, how do you know how to choose your surgeon? So I always say, first of all, you have to see a lot of results, the good results. You want to see lots of consistency. You want to see a lot of different results on different types of faces or bodies or breasts, whatever you're looking for. You have to see, and you want to see different degrees of difficulty, like not just like these slam dunk breast augmentations that volume look good, or just or these little chip shots. That this person's already pretty, and you do a little thing and get rid of that looks pretty. That's fine. It's not that easy.
Yeah.
You want to see degrees of difficulty in somebody. You want to see the depth of skill set in a person. That's number one. So you got to be convinced of that. Number two, then you got to go see him. You got to talk to him and to see if that he is a nice person.
Sure.
That he has good, that he's actually cares about what he's doing.
Who do you vibe with?
You know?
Yeah. Who do you?
Yeah. So that he has the same vision as you, and he sees and he understands your desires and wants and so forth. You know, that's number two. And then number three, that you have to make sure that you trust him or her, because if things don't go right for some reason, you know, are you going to trust him to take care of the complications if it happens? Those are like super important things in choosing a surgeon. And you're a great surgeon, you have good skill set, good business manners, you know, like it's obvious. So that's what makes you successful.
Yeah. So what people have to understand too, you're not getting just a procedure. You're not buying a procedure. You're not going to say, okay, you know, I just want this procedure done to me. Because you could say, you know, I can say Dr. Kao does an amazing endoscopic style lift, but it does not mean that you go to any surgeon and they do an endoscopic style lift and it's great. So it's not something where you ever can compare saying, okay, deep plane to endoscopic lifting or deep plane into endoscopic. Like you can't do that, because I could say I do deep plane. Someone else says they do endoscopic. You say you do endoscopic and a deep plane. There's all these different names for everything. And in the end, one person doing endoscopic or deep plane is nothing like the other 99 or the other 100 doing it. There's a reason you see a long list or a long assortment of photos on somebody's website and they all look good. It's not because they went and learned a technique and do a technique. It's because they're a good surgeon. So in the end, when you're looking for, you know, the procedure, you need to find the right surgeon, not trying to find the name of a procedure that like you think, okay, endoscopic is what it's going to be.
I think the really key is, you know, when you're dealing, like what I find is you can look for a surgeon who's a good mechanic, you know, like it's a mechanical person where, you know, listen, I have these jowls, I have this jowls, I have this neck, you know, I have turkey necks, can you get rid of it? Yeah, I can get rid of them, that's no problem. Okay, great. You know, so it's a mechanical. So the neck is mechanical. There's never any, like the neck and jaws is mechanical. There's never any like me arguing like what's a good neck, what's a youthful neck, what's a good jaws. It's very universal. It's long, skinny, and tight. Good jawline, long, skinny, tight, clean jawline. That's it. Right? So it's very, not a lot of variation. Okay. But here, upper two-thirds face is more artistic. It's kind of like judging ice skaters, you know, like when you with artistic impression and technical merit. Here's technical merit.
And how good looking they are. But please continue.
So here's technical merit. Okay, you have to know how to do all this maneuver and get a good neck, right? So, but here's artistic impression. Like, how far do you raise the brow? How far? How much do you tilt the eyes? A little bit, a lot, dramatic. Like, how does the cheek go up? And how about the lip? How much fat transfer? Like, so those are like it's very, very artistic. So those kind of things, you really have to spend time. So as a patient, you really have to communicate that with the surgeon and make sure that he or she understands what your likes and dislikes. So that's what the key picking out surgeons also is to make sure that this person understands what you like and what you don't like.
Yeah. And that's why surgeons have to be very good at reading people, very good at communicating. If not, no matter how talented they are, I think their rate of success is dramatically lower, just from being on the same page with the patient. Can you do a nose revision and a lip lift at the same time? That's a yes.
Nose revision and a lip lift?
Same time. Yeah.
I don't know. I don't know if I can do nasal surgery. Maybe not. I get a little nervous about doing it in the open.
No, that's fine. I do it all the time.
You have more idea, but I don't like to do that. But because I have seen necrosis, so I just.
How can you reduce the appearance of nasolabial folds using surgical techniques? I would say what we're talking about, different types of facelift. What I'd say give a strong advice against is people try to cut out the nasolabial folds sometimes, which is fucking insane, but they do it. People try to put Gore-Tex implants or Alloderm implants throughout it, which only makes it broader and bigger. So I would say stick to facelifting.
Well, I think nasolabial folds are it's a very difficult treatment, because even babies have nasolabial folds, right?
Yes.
And it's natural. But when it gets too deep, you have then becomes a little more older appearance. The reason with nasolabial folds is that that occurs is because the maxilla recedes. And when it recedes, this deepens and the cheek falls over as it drops down. In my hands, dealing with nasal you have to know how to do a good endoscopic cheek lift.
Yeah.
To lift all.
Yeah, I agree. It's mainly lifting, and then you can always do little tiny fine tuning with either fat injections, filler, radio frequency treatments to fine tune it. But the majority of it is lift it up, get the weight back off of it, right, back from whence it came. How long does a ponytail last realistically for someone in their 40s?
Okay, well, I mean, I've had people. My first one that I did in, this is going to date me, but I'm going to say it's 1999, and that patient came back to me 20 years later and they still look really, really good. That's a ponytail lift, not a ponytail facelift. So she came back 20 years later to get her neck done. At the time I did her, she was in her late 30s, almost 40s. So it does last. It can last a long time. So people always like, well, how long does it last? How long does it last? So it depends on a lot of factors. Like, because if you are 65 years old and your tissue is not so good, any kind of lift is not going to last that long, because you're at that point where the cells aren't talking to each other, the hormones are not really being produced, the tissue degradation is advanced, right? So it's not going to be quite as good. If you do it in your 30s and 40s, it'll last quite a long time, 10 years, 15 years even, if you maintain it. So in these days, maintenance is also very, very key, right? So a little bit of Botox will help, regular Botox, and occasionally some kind of little volume replacement, that may help a lot. So, you can maintain quite a long time these days, okay? So when you're in your 30s and 40s. But if you have really bad tissue, in your 30s, 40s, it's not going to last quite as long.
Yeah.
So it's all kind of relative, right? But I know that what I do, because I tighten everything from top here to bottom neck in the deep plane, it should last about as good as any facelift out there.
So let's, this is called the reality pill. So let's address a fallacy here. Some surgeons tell patients that since they're younger, they need to do less of a lift, meaning less of a release in general, meaning you go do an endoscopic lift, you can release less. You do a deep plane, you can release less. Is that true or false?
I think I'm going to say false.
It is false. Yes.
Because
correct.
Correct answer. But for me, for a young patient, I think the worst thing to see is to have a scar. Have a scar here that looks so visible. It looks so cool.
It's the worst.
You really have go to a good technician. You're a great technician, Ben. I mean, you can really get a good scar. But some of these people I see, there's nothing more sad to me, and it kind of aches my heart when I see a beautiful girl, and then I look around, and I see these scars in the ear.
And they did a mini lift. I did a mini lift.
Yeah, it's like a lifestyle lift or a mini lift. That, and the scars are bad. I mean, it's such a turn off.
But why do those scars happen? It's because
tension.
It's about tension.
Because tension.
Correct.
So what the policy is, I'm going to do something really, really easy, and then I'm going to do a little bit, and then they try to get you a little bigger result, and then you pull, and now there's tightness because they're trying to get a lot more skin, but they're going to do a little bit of release, and then so the closure is under tension, and then the scars are bad.
Yeah. So release is release. Appropriate is appropriate.
You have to do a really good release, and in order to have a closure that doesn't have any tension.
Yes.
So even in my endoscopic, I don't have any closure really except the scalp incision, but still.
But you worry because you worry about result, natural look, and durability. If you release, you get a more natural look, you get a bigger result, and you get more durability. If you release less in your lift, you're going to get less of all those things.
It's the same thing where if you want to put this thing up here, okay, But if you don't release down here, so you can easily slide that up here, and so you can pick it up, move it, put it back down, and have a scar down so it doesn't move anymore. So that's a good thing. But if you try to pull it, when you haven't done a proper release, when I pull this over, it's not going to last, it's not going to stay. So you have to really pick it up and move it. So you have to release properly in order to be able to pick it up and move it, and to have it be stuck back down in a new place, at a higher place.
Yeah. So this we kind of touched on briefly, and Tim Martin talks a lot about this with like an early intervention lift. But is it better to consider a surgical facelift sooner rather than later once you see laxity starting?
Oh man, that's a sticky questions for me.
What do you think? I tell people, because I get this question all the time, I want to know how you answer it. So when patients ask me, I say, well, there's two ways to look at it. And I tell them one is, you're somebody who, this stuff's bothering you, and you go to a technician and the technician tells you, I can get this for you. And it makes sense. And you go over the risks and all that. And you say, okay, I'm willing to undergo that downtime in my life. The other is you're trying to, decrease the amount of times that you do something in somebody's life. And you say, okay, you could wait a couple more years if you want. And it's all dependent on personality. Somebody who wants things to look better all the time, they do better with an early intervention lift. And then realistically, the benefit of an earlier lift is that later you can maintain kind of a more maximal position your entire life versus somebody who droops so much. You go try to lift them as much as you can, you're never going to get them maximal in one lift. Complicated answer.
Yes, and I have an answer that, like, when I get asked that question, and my answer is probably not as PC to my colleagues, who does a traditional bilaminate smash facelift. So what I mean by that is that you separate the skin away from the fat, and then you separate the fat away from the muscle, and then you lift the fat and return the skin horizontally, right? So that's kind of traditional smash biplanar facelift. Okay, so I always when I was learning that operation when I was younger, when I was in residency, I did not like it because the fat that feeds the skin, these little tiny capillaries of fat that feeds the skin, is very important to the vitality of the skin. So the skin, these little capillaries, you have to cut it, right? So you have to lift the skin really thin off of the fat. Then you have to cut these little vessels that goes from the fat that feeds the skin. You have to cut it. And then you have to go underneath the fat and lift up the smash and move the fat. Well, the skin gets devascularized with that maneuver, with that dissection. And then the fat also gets devascularized when you pull on it. So a lot of times the fat gets devascularized and then the skin gets devascularized. So when people ask me, is it better to do a procedure, a facelift when you're younger to nip in the bud? I kind of said, well, it kind of depends on what kind of procedure you're doing, right? So if you're doing like a bilaminar type of skin lift, I think over a long run, when you devascularize the skin, devascularize the fat, the skin will thin out and probably is not going to be good for you, especially when you're so young, right? It's not a worthy trade-off. It's plus the scars you get. So like for me, that's why I do things without the cutting, and then when I do it in the deeper plane, if you will, I don't. When I go endoscopically, I see a vessel, I go around it, I don't cut it, I go around it, so the fat stays with the skin, and so we don't really kind of devascularize the skin or the fat. So I think that when you try to get things done without doing a lot of injury to the skin or the fat.
I agree with that. And you do see revascularization, neovascularization with people who've had a lot of skin trauma as well, and that doesn't look good overall.
Yeah, you see that what happens when you'll see that the skin thins out, and then you'll see that the collateral circulation dilates, so you see more vasculature on the skin, and the skin sort of thin and sort of translucent.
Yeah. So Sad Booty Adventures asks, buccal fat reduction for somebody younger than 25, is that a good thing?
Oh, I get asked that quite a bit. Of course, it depends, right? Yeah. I mean, when you have like really kind of cherubic, really a lot, it's all done it's all case by case, really. I mean, when we have really cherubic fatty face and they're really sort of abundant. Okay, you're gonna remove a little bit. Okay, so the key is to remove conservatively, not try to remove everything. Okay, so but a lot of these people, a lot of these women, these little girls or young girls, or these sort of Instagram girls that you probably see and I see, is that they want to have this sculpted look and sort of chisel thing, show that the face, and they want a buccal fat pad removal. I don't really like to remove the buccal fat pad because you will need it later on because you will lose some fat there.
So not that far down the line, a couple of years.
Right. After a couple, wild nights for a year, they'll shut it. So when they get jetted around in the Caribbean, like that. Anyway, so what I prefer to do is the KOG thing, where you create a cheek lift. So you're not actually removing the fat, but you're sort of repositioning the cheek and really hollow this out so you can create a curve, the OG, the cheek and the lower part of the face like that. So that's what people want. But what I'm saying is you don't need to have a buccal fat pad removal for that result. Okay, so my answer is really no. But if there's somebody who is really
super full, will always be full.
I know that if I try to remove this up, it's not enough. It's not going to give them that nice curve. I do have to remove it, right? So I move a little bit.
Yeah. All right. So let's see. Now we have some more questions over here. So I got a deep plane. So it says 6 years later, I need another one. Is this normal? So I would say it's common for smaller lifts to last about 5 years or so. But yeah, if you get a bigger lift, it'll last longer. Next one, I've got scars in my head and the parts. Can you fix it by adding hair or minimize the scar? We have to see it to know what is the best age to do a ponytail lift. It all depends on the face.
I always say this when people ask, what's the best age to do a ponytail lift? I say, I don't treat age. I treat problems at age. Okay. It's my youngest is 17 years old. Okay. So, and she had a burn and she had this really terrific looking face. We made her feel better because we hide this, we create a better jawline, so hide all the scar from the burns. So it's really not the age is the problem. If I can see that I can help you and make things to give you the look that you like, that you want, then that I'm confident in delivering, then it's okay.
Yeah, I agree. Here's a question again from Sad Booty Adventures. Love that name. What do you prefer for younger patients, Bellafill or fat grafting? I've got obviously fat grafting. Please don't use Bellafill, Artifill, Articol, silicone. Don't use those things. Fat grafting.
Those things are permanent and they may look good for a little while, but over time they're going to create such problems for you. And I'm seeing these patients that are a little bit older with the Bellafill when they were in their 20 years ago or 15 years ago, and they form granulomas. It's very, very, very hard to get.
Very hard. Impossible. It's so stay away from that kind of stuff. A beer asks, would you let Dr. Kao operate on you after about 10 years? We'll see how bad I look, but yes, I would love for Dr. Kao to do that. All right, cool. Well, the other ones I think we've already answered. So we've got an hour and a half. I would say we will call it this recording. I think a lot of people definitely want to see it later. I think it's pretty educational. I like having residents and doctors who come visit actually refer back to these podcasts to kind of get concepts of what we think about, what we talk about, especially doctors who come visit me, and I try to explain to them that this is not the only right way to do it. And they're like, what do you mean? Well, there's this other doctor who does it this way. There's this doctor who does it that way. And it's great kind of brain exercise. And I think it's nice being people like us who talk, who do things completely differently, but agree on everything the other person does, which it's rare. Say.
Well, that's what's the beauty and fun about plastic surgery, right? So you can get to beauty in many different ways, and beauty is either the beholder as well. So it's not really plastic surgery. There's no rule book for plastic surgery. It's not like a hernia repair. So it's not like when you go to a hospital, they dictate what sutures you got to use and what mesh you got to use and what technique you should use, and insurance will pay this much only for this technique and so forth. So plastic surgery is like what you can deliver for the patient and what patient wants, right? And in your hands, what you can create. So that's the beauty of plastic surgery. You just have to find the surgeon that really fits your goals and your personality.
Yeah, you go to the right surgeon. It's a beautiful, artistic, complex kind of endeavor. You go to the wrong surgeon, the same thing turns into the wild, wild west, where plastic surgery, anything goes. There is no rule book.
Like in plastic surgery, especially your face, I always tell people your face and tummy tucks, facelift, tummy tuck. Those two things are so forgiving. And tummy tucks, at least, if you do a bad tummy tuck, bad scars, the scar's bad, too high, it's very difficult to fix. Okay, it's almost impossible to fix. Okay, but at least you can cover it. Okay, but with the face, there's no room to hide.
Yeah.
You got to make sure that you go to a person that is going to deliver what you want, but without all the scars. So it's not something like you really have to do your research. You really really find somebody who will take the time and care and to really do a meticulous job.
Yeah.
So because those scars, once they're there, is very hard to fix. Once a trach is destroyed, it's very hard to fix. Once a hairline is destroyed, it's very hard to fix. Those are like really difficult things to work with. And I see these people, some of them are really, really difficult to fix. And I try my best.
Yeah. Looking fake, looking operated, looking scarred. These are unacceptable when you're going to somebody and trying to get an improvement, in the way your face looks. You can't get look better just by doing this, but then the rest of your face looks weird and fake and scars.
I always say, it's really kind of, it's nice when you get it. So the difference between a result that people goes, oh my God, did you see Mary? She looks amazing. I don't know what she did, but she must have did something. She looks so good. She looks like she's like 20 years younger. I don't know. Did she go on a diet? What did she do? Like new hairdo or whatever? That versus someone go, hey, did you see Mary? She had a facelift. That's not good. And the difference between the two is millimeters.
Yeah.
It's millimeters in the face, right? So the scars is all about what you can see and what you don't see.
Yeah. You want people hating on you because you look so much better than them, not talking shit about you because you look so fake. That's how it should go down. And if you want to find Dr. Kao, it's Kao, K-A-O. Everybody says, how do you say his name? Kao? I'm like, it's not that hard. Kao, Dr. Kao. So Dr. Kao, you can find him on Instagram as well. And he's got like amazing photos there that everybody will love.